So my name's James Dodd. I'm a clinical lecturer in respiratory medicine. So it's part of this integrated academic training. So half of my life is completing training as a respiratory consultant at North Bristol in the BRI, and the rest of my time, 50% of my time, is doing postdoc research here. I've moved from London, where I did a lot of my research, to Bristol. So I've been trying to set up links and collaborations locally in people who may be interested in things that I'm interested in. If I'm saying things from particularly in your area of expertise that you think we can skim over, please put your hand up and tell me to skip over it. If there are things that you want me to slow down or you want to ask questions, please feel free to do that. Okay, right. So I thought I'd just start off, if I'm going to give a talk about cognitive function in COPD, just by defining what COPD is. If you've not heard of it before, then you would probably know somebody with it or have seen somebody in the street with it. It's that common. It's a common, preventable, treatable condition. These are the latest 2011 definition. There's been some refining over the years to try and reflect some of the findings and the developments in defining the disease. It's characterized by airflow limitation, hence the obstruction part of the title, and that's picked up on the breathing test, the spirometry, which we do in clinic. It's sadly usually progressive, and one of the things that we now realise that we didn't before is that the key finding is that there seems to be this enhanced or abnormal inflammatory response to the noxious stimulus. So clearly in the UK and Europe, 90% of that's going to be tobacco smoke, hence your interest. But globally, its biomass fuels is becoming an emerging problem with COPD. So they may have never smoked, but they can still develop this COPD. Importantly, it's characterized by these horrendous exacerbations, or a lung attack. So often an infection will set up breathlessness, cough, sputum, and they'll have to see their GP and get some antibiotics or some systemic oral steroids and have treatments. Occasionally, they're admitted to hospital. And these exacerbations are key in COPD. They accelerate the decline in lung function and are associated with an increased mortality. So they're really something that we need to bear in mind when we're defining what COPD is. So that's what COPD is. Okay, so just some headlines about the disease. There's about 1 million in the UK that have got the diagnosis. The other thing to say probably is that emphysema, people may be familiar with that title. That's part of COPD. It's kind of the pathological variant of COPD. So that's within that heading. But importantly, there's another 2.2 million who've probably got it and just aren't diagnosed with it. They may go and see their GP and get some antibiotics in the winter, and they just call it winter bronchitis. In all likelihood is if they've smoked enough or they've had other risk factors, they've probably got COPD, but it's not been diagnosed. So there's probably 3 million people in the UK have got it. If you scale that up globally, you've got 210 million people who've got it. It's a massive global problem. And it kills people. 3 million deaths per year attributed to COPD. That's 5% of global mortality. Sadly, unlike things like heart disease and cancer, which are on are dropping, this isn't. Because the projected deaths attributable to COPD are going to thought to increase by 30% over the next 10 years. Unless there's some drastic approach to particularly smoking cessation that's going to try and have any effect on that. And therefore, by 2030, it's thought that COPD will be the third leading cause of death worldwide. So here I am talking about a lung disease affecting something outside the lung. And it's now recognised that COPD isn't just a pulmonary condition. And I'm going to use heart disease as a route in to explain that, because that's quite a bit better defined so far. So this is a graph of MI, so heart attack, and COPD, and there's a GP practice database, 1 million patients in this database, and they looked at patients with COPD and without COPD, and they looked at the incidence of heart attack, and you can see that those with COPD have clearly got a higher risk of heart attacks. That's even when you control for the things that we know cause heart attacks, in particular smoking. So there's something about diagnosis of COPD that is causing 10 times the risk of heart attack. And this happens at all stages of COPD. It's not just those with advanced disease. The other thing to say about these comorbidities in COPD, so these manifestations outside the lung, This graph here is from a large epidemiological series in America, and what we've got on the bottom of the graph are gold stage. So that's effectively just one measure of severity of COPD. So gold stage 3 and 4 is more severe, gold stage 0 is mild, and then you've got the normal at the other end. And this graph is meant to just demonstrate that having these comorbidities and COPD increases your risk of death, and that increase is at all stages of disease severity. So the comorbidities they use in this example are diabetes, hypertension, and cardiovascular disease. So this is now thought that COPD is not restricted to a pulmonary condition. It's a complex multisystem syndrome. There is some debate that's ongoing whether this is just that these comorbidities happen to occur more frequently in COPD or whether it's something about COPD itself. Almost regardless of that, if you have a comorbidity with COPD, then that is going to impact on symptoms, quality of life, the likelihood of a patient being admitted to hospital, and increase their mortality, as I've just shown. There are also implications for people like us who are looking after patients who come to clinic. Clearly, if somebody comes to see me in respiratory clinic with COPD, then perhaps I shouldn't just be narrow-mindedly focusing on their lung function. I need to be looking at their comorbidities and treating their heart disease, the diabetes, their osteoporosis, and the other things that go with it. So that's where it sits. And I would argue that cognitive function, the area I'm interested in, is particularly important with long-term condition like COPD. It's going to have a massive impact on their ability to self-manage, and a lot of the interventions that we do, like pulmonary rehab. Cognitive function is going to be an important part of that, and we need to tailor our treatment to their needs. So when I present this to my respiratory colleagues, and it's just smoking. They're heavy smokers. You've got a smoking-related lung disease. All of these problems are related to smoking. And there's an argument that runs that way, but there are some strong signals to suggest that it's not just smoking, and that's what this slide is about, really. So lung function itself is an independent predictor of mortality above and beyond smoking, and then if you look at populations of non-smokers with impaired lung function, then it also predicts mortality and some of these comorbidities. And then there's also, a list of comorbidities that happen in COPD that you can't easily explain due to smoking alone anyway. So musculoskeletal weakness, diabetes, and depression. So what are the mechanisms? Well, overwhelmingly the most common one that's cited is a systemic inflammation, a systemic disease that manifests itself with these problems outside the lung through systemic inflammation. But there's been other things like genetic predisposition. So not everybody who smokes gets COPD. And so perhaps the same genetic profile that predisposes to COPD predisposes you to those comorbidities within COPD. There's also a theory that COPD is a process of accelerated aging, that the effects of chronic hypoxemia, so low oxygen levels, can have these effects outside the lungs. And physical inactivity, again, is a characteristic of this disease. They're breathless patients. Physical inactivity, particularly in early stage disease, predicts quite a lot of these outcomes. And so the relationship between physical inactivity and systemic manifestations is of particular interest at the moment. And of course, its impact on systemic inflammation. So a lot of these other risk factors could be mediated through systemic inflammation. So the systemic inflammation stories, this meta-analysis here that I'm showing shows that there's both pulmonary and systemic inflammation in COPD. And these markers increase during these exacerbations that I've talked about. But you need to bear in mind that systemic inflammation is characteristic of lots of other chronic diseases. It may not be specific to COPD. And it's also a part of aging. Inflammatory markers go up. But it has led to this idea that there may be an overspill hypothesis, so that there's this inflammatory organ, the lungs in COPD, that then overspills into the systemic circulation and can mediate its effects outside the lung. And that's what this schematic from a review shows. So we've got the noxious stimulus, in this case at the top is the tobacco, which then causes lung inflammation, and through systemic mediators, so interleukins 6, particularly TNF-alpha, and some acute phase proteins in the systemic circulation, then have their negative effect on the extrapulmonary systems. And we've got the yellow circles at the bottom is highlighting the main ones, so heart disease, osteoporosis, diabetes, anemia, and depression. What I would suggest is, and something I've been working on, is that there's another yellow dot, which is the central nervous system in COPD and cognition. So to summarize that first bit, COPD is a complex multi-system disorder The comorbidities are often present early in the disease. They have a negative impact on mortality and morbidity. It appears to be independent of shared risk factors, in particular smoking, but we're not quite sure why. So there are some more studies coming through now. So I've had to update my slides over the last 12 months in particular. There's been some longitudinal data, and the top one here is a study that was published in JAMA Neurology this year, which shows that over a 5-year period, I think, the incidence of mild cognitive impairments, this is using neuropsychological test battery definition, was 27% in patients who've got COPD, and that if you'd had COPD for over 5 years, you got twice that risk. And then in the next cohort, the CADE study, which is a 25-year follow-up, looking at cardiovascular risk factors for dementia, they said that a midlife diagnosis of COPD was associated with a 1.85 hazard ratio of mild cognitive impairment. And then if you look at certain populations within COPD, that it's more severe and more frequent. In particular, going back to hypoxemia, the low oxygen levels, if you've got low oxygen levels in COPD, then the incidence of significant cognitive impairment is 60%. So that comes from studies back in the 1980s when we were deciding which patients to give oxygen therapy to. So at the beginning of these oxygen therapy trials, they do a neuropsychological test battery, and they found that significant cognitive impairment in that group. So, has also thought that COPD have a trajectory of more rapid cognitive decline. So this was a study looking at patients with COPD who were using oxygen and had functional impairment as well, and in that group, they used a 35-point validated scale of cognition and found that their rate of cognition was greater if they had low oxygen levels. But it's not all oxygen related. So even patients with COPD who have normal oxygen levels have cognitive impairment. And going back to those oxygen therapy studies, so those hypoxemic patients, if you gave them oxygen therapy, their neuropsychological tests didn't improve particularly. And then it also appears to be independent of the severity of their lung disease, and that goes for a lot of comorbidities. So hypercapnia is a low CO2, so the buildup of waste gas. So if they're in respiratory failure, that can often cause clouding of consciousness, but it appears to be present even in the absence of that as well. And as I've said before, I don't want to repeat myself too much, in COPD patients, the cognitive impairment, again, is not wholly explained by smoking or vascular risk that we measured. So it's a busy slide, but this is just a table from the review that I did at the beginning of my research, just looking at studies of patients with COPD, and they're split into the top half with those with hypoxemia or low oxygen levels, and the bottom half is those without. And what I tried to do was the white boxes are the cognitive domains that were tested in that study, and the black dots are the ones where they found impairment. Now, I'm sure you get this a lot and bang your heads against the wall that if you do lots of cognitive tests, you're going to find some of them are going to be abnormal. But when I tried to summarize this in terms of, but you can see pretty much if they were going to test the cognitive function, it was going to be impaired in all of these populations. But the other important note is to say they found it also in the absence of hypoxemia. So what I did was we recruited about 110 patients, and there were 3 groups. There were, control group, age matched, and then there were patients with COPD who didn't have low oxygen levels, and then there were patients who were admitted to hospital with an exacerbation who were about to be discharged home, and those were our 3 groups. And we did a battery of tests, which the neuropsychologist I work with, I don't know if anybody knows Martin van den Broek. He works at St George's. I think he's traumatic brain injury is his background, and stroke. But he helped me put this battery of tests together. So we did the test of adult reading, we did an MMSE screen, we did the raised complex figure, we did the memory test from the Wechsler memory scale, edition 3 at the time, and we did some working memory, processing speed, and some DKEF's executive function. So that's the battery that I use with these patients. I've got some red lines just to help with basically the summary of this is the COPD E group are these patients who have exacerbated or are in hospital, and the COPD S group are the stable ones, and the control group there. And basically what this shows is that the exacerbated group have got significantly worse cognition. So we've used a age standardized mean here, so a normal 10, standard deviation of 3. So they've got reduced verbal memory, trail making, so executive function particularly is impaired, both COPD groups, but particularly in those in hospital. And visuospatial ability was another significantly reduced ability. And then that processing speed seemed to predict some outcomes in hospital. So the SGRQ is a disease-specific measure of health status, and so if the worse your health status was, the worse your disease was, the worse the processing speed, or vice versa, and that those with worse processing speed appeared to have to stay in hospital longer, or did stay in hospital longer for whatever reason. And then the other graph on the right is a change score. So in those that are in hospital, we then repeated their neuropsychological tests at 3 months, usually, an arbitrary period of time, but we'd expect them to have recovered from their exacerbation at that point. So we used a T-score change to account for practice effect and regression to the mean, and effectively that's a flat line, suggesting that they haven't improved at 3 months. And in fact, a lot of them didn't show any practice effect, which started to raise the question, have they got encoding difficulties? And we intervene with these patients in terms of educational material quite intensively at discharge. How effective is that going to be, given this data about cognitive function? So in summary of that, so hospitalized patients with exacerbation, half of them had moderate severe impairment. So it's important to say that we excluded patients with known history of dementia here. So this is an unrecognized group of cognitive difficulties. They appeared to associate with increased length of stay and poor health status, and apparently didn't recover when we assessed them again at 3 months. Of course, the argument could be, well, that's just they've always had that cognitive impairment. That's not a change associated with the exacerbation. That's another question itself. So onto the second half, which is brain pathology. And so my study was, we had a 3T scanner in St George's, and we decided to image the stable COPD patients and their age-matched controls. But before we did that, we just looked through the literature, and there weren't at that point very many studies in COPD looking at MRI or CT. An audience like this, I apologise in telling you this, I'm sure you know, that from what I reviewed at the time, and these articles here would suggest that smoking itself is related with some brain pathology, so cerebral atrophy and frontal grey matter volume loss and density were the kind of things that thought to be associated with smoking. But there are some studies looking at impaired lung function, not necessarily a diagnosis of COPD, but impaired lung function. And they've shown that impaired lung function is associated with increased white matter lesions, both in non-smokers and independently of smoking. And then when there were studies trying to those with a diagnosis of COPD, this was the Rotterdam imaging study, and they chose a cohort of patients that used inhalers, so not a particularly sensitive description of COPD, but it does capture quite a lot of them, and they found that this group was associated with white matter lesions. In a smaller group, but who were well characterized for COPD, they couldn't find a difference in brain volumes or white matter lesions. More recently, there's been a few other studies suggesting that there's increased cerebral microbleeds, which my understanding is that it's kind of susceptibility weighted imaging on MRI and can be a marker of cumulative vascular events. So that there seems to be a vascular pattern of damage in COPD. They've also been shown to have reduced hippocampal volume and regional grey matter volume differences in COPD. These are small studies, but they have also gone on to say that those differences were perhaps associated with markers of disease severity. This was the summary of results of the imaging study that I did before. So we looked at brain volumes, and there was no difference in brain volumes in our stable COPD group and their controls. And then we did white matter lesion volumes, and this is where they became more significant. So we did, again, find significantly great white matter lesion burden differences in patients with COPD. Does anybody recognize this? To wake people up. Does anybody recognize that? Anybody? No? Yeah. Yeah, it's DTI, but specifically? No, not music lovers. It's the album cover from. Oh, there you go. Album cover from Muse. So I thought this was really cool because I was in St George's cycling past this advert for the Muse album cover, thinking that's my research. I must be cutting edge if it's on an album cover. Anyway, so yeah, diffusion imaging. And I hear from Crick, I've just been over at Crick, that Targa are big users at Crick. So you know, I'm sorry if you know all of this, but so we used diffusion tensor imaging. We used track-based spatial statistics to look at group differences. So these are slices throughout the brain. So what we've got here are the white to red scale for areas on the white matter skeleton, which is a sensitive measure for white matter structural differences, which show widespread white matter differences through all of these areas between the controls and COPD patients. And then we did, to kind of as a backup to the fractional anisotropy, we did mean diffusivity, and they were identical patterns, so showing a bit of internal consistency, and that those differences accounted for 46% of the white matter skeleton. So, you know, the picture is building up. Really, these patients appear to have quite damaged, widespread damaged white matter tracts. We then fed into the analysis the differences in smoking and cardiovascular risk and cerebrovascular risk that we'd measured, and I was fully expecting at that point that the differences would disappear because we'd effectively got a smoking group and a non-smoking group, and if you were, you know, by definition, that they would disappear. But you know, as much as the limitations of these statistics, they did show that perhaps there was still some white matter damage independent of smoking and vascular risk, so something else was causing it specific to COPD. And I think you do a lot more of this, so functional imaging. I don't know whether you do resting state. Have you done resting state in any of your projects, or is it more kind of getting them to do an intervention? Resting state. So so my understanding of resting state is that there are 8 resting state networks in the human brain. So it's a reflection that the brain is always active even at rest. So this imaging isn't to do with getting a patient to do a task. It's to scan them for 6 minutes, I think, effectively. And you're looking for temporal changes in oxygen consumption and to see how these congregate together. And so there's 8 networks. There's a frontal network, a parietal network, an occipital network, and then there's something called the default mode network. Now, this is where it gets a little bit more kind of wishy-washy potentially, in that the default mode network, there's lots of theories about what it does, but perhaps it's kind of an internal monitoring of the external environment. And so anyway, we found these 8 shared resting state networks in patients with COPD and the controls, and then we wanted to see whether there are any differences in these networks. So this slide are the 8 networks. So the networks, just to kind of zone your eyes in, the white to red areas are the shared resting state networks. So you'll see patterns of occipital, frontal. The default mode network is the top left with a kind of central and blob and 2 red blocks either side. And then the blue to green kind of scale are the areas within those networks which are significantly more activated in this case in COPD. So pretty much 7 of the 8 networks were significantly more activated in patients who got COPD than their controls. So that led on to, you know, us drawing that to a conclusion that there is white matter microstructural damage throughout the brain in COPD. That's been reproduced in a couple of other studies. There's widespread abnormalities and functional grey matter activation, so the consumption of oxygen in these resting state networks. And when we put in the differences in cognitive abilities, that may have accounted for some of the differences, so we thought that might relate to their cognitive difficulties. And that the smoking and stroke risk didn't appear to account for the grey matter difference, but not the white matter difference. So we're thinking that perhaps this is an effect on the cerebral microcirculation. That's where we are at the moment. Which leads me on to the final couple of slides, which is about what I'm doing now. So this post is to try and see whether I can set up some research independently, and we've just got some funding from the British Lung Foundation to look at a similar study, but in healthy smokers, to really tease out the difference. Is this a COPD effect independent of smoking? And also to explore some of the differences. So really making a big effort to kind of characterize these patients in terms of microvascular and macrovascular damage. And we're also starting to try and look at cerebral perfusion, so looking at arterial spin labeling, and we're taking some measures of systemic inflammation. So, and the other thing is to try and see if we can translate this to more low-tech or widely available techniques of looking at vascular integrity and cognitive function. So we're not using a 2-hour battery of neuropsychological tests, we're using the Montreal Cognitive Assessment, which has been validated in COPD. It's much more sensitive. It may be just by virtue of the fact it's got an executive function test and the MMSE hasn't. And we're doing things like retinal photography, which is pretty simple. It's part of the diabetic screening program. You do a picture of the back of their eye and then you can assess that. I'll show you a picture. And then a urine dip for protein. That's a pretty sensitive measure of the small microvascular bed in the kidneys, and that's been shown to predict lots of vascular outcomes, quite sensitively actually. So we kind of characterising them in this fashion. So the young lady that's got the kind of collar on there. This is the pulse wave velocity, so that's a measure of stiffness of the aorta. And that, aortic stiffness has been found in patients with COPD, and it's thought that perhaps the stiff vessels are a mechanism whereby it transmits more aggressively the impulse to the end organ and can cause damage that way. So it'd be interesting to see whether this aortic stiffness relates to perfusion and damage in patients with COPD. And then there's some pretty nifty software that we're using looking at the retinal vascular measures as well, seeing whether that kind of is a good measure for cognitive impairment and some of the brain damage that we see in patients with COPD. So that's it. Thank you very much for listening on a hot afternoon.